بسم الله الرحمن الرحيم.
Five views of the abdomen, 4 views of the abdomen, and 1 of the heart to detect free fluid. We'll talk about that. And then you can do CT and MR also in trauma. What FAST can do? FAST stands for Focused Assessment with Sonography for Trauma. What can it do? It can detect free fluid, as we know. Hemoperitoneum versus simple transitate. Sensitivity is 78 to 99%. Specificity is also good, 93 to 99%. But only when free fluid is present. It is non-ionizing, it is cheap, it is bedside, you can take the ultrasound anywhere unlike a CT scanner. It has also replaced diagnostic peritoneal lavage in the blunt abdominal trauma workup. What are the limitations? It can detect and characterize pancreatic injury. In a study done by McGann, it was shown that 70% of splenic were picked up, 14% of hepatic were picked up, 25% of renal injuries were picked up, and 0% of bowel. So it does not pick up bowel injury at all. Overgraded by 6% and undergraded by 53% and missed 11%. So it is not accurate. When you are grading injuries, and why do you need to grade injuries? Because that determines how you are going to manage these injured patients. Time to evaluate organs appropriately. Even if FAST was sensitive and specific, significant abdominal trauma still can be present without hemoperitoneum. That is the problem. You will not have free fluid in the belly in spite of significant injuries. In stable patient, CT needed for source, and in unstable patient, FAST will waste time. CT is the imaging modality of choice. Negative CT can reliably exclude significant injury, as shown by Livingston in a paper in 1998. Multi-detector CT has advantages. It is time efficient. IV contrast demonstrates parenchymal opacification and can depict vascular injury. Oral contrast is no longer required. Radiation, though, remains a problem. Not anymore. With the newer generation scanners, the Siemens flash that we have, the radiation dose for a cardiac CT even is less than a millisievert, or less than 1 millisievert. And the background radiation that we all get per year is 3 millisieverts. So radiation is no longer an issue, but with newer generation scanners. Useful signs in trauma. You need to assess hemodynamic status. How can you do that with CT if a patient is hypovolemic or not? Hyper-enhancing edematous bowel is one of the signs. Flattened inferior vena cava is another sign. And the third sign is small size of the spleen. This is called hypoperfusion complex. That means patient is hemodynamically not stable. Useful signs in blunt abdominal trauma, a sign called sentinel clot sign, which is at the site of trauma or laceration in a vessel, you can see high attenuation or high density fluid, that is active extravasation. Water density fluid collections in trauma, here you can see within the pelvis water density fluid collection with loops of bowel. Interloop fluid as depicted here, fluid within the loops of bowel, and high attenuation foci or focus equal to a nearby artery. Here you see within the spleen, and obviously splenic laceration. There is free fluid as well in the belly. Vascular injury imaging predictors of treatment as shown by a paper here. This is non-aortic acute vascular injury. So this is parenchymal organ injury. Linear AVIs in this study were 4 times more likely to require intervention, surgery or embolization than round morphology AVIs independent of hemodynamic status. Linear AVIs were areas of extravasation which was active and branches of an artery. From branches of an artery, round was equivalent to either a pseudoaneurysm or a venous bleed, and I'll show you both. Here you've got round morphology. This was a splenic trauma patient. This was managed conservatively. No intervention was performed and the patient did very well. All the clot with time got smaller and this bleeding stopped. Here you've got a linear AVI. Look at this. Here is a rounded morphology at the end of it, but look at this linear AVI. And this was actually an active arterial bleed. I'll show you more images. Here is the liver laceration, significant amount of trauma in the liver. Here is the linear AVI, and look at this. This is actually a branch of right hepatic artery which was actively bleeding. We went in. This is an angiogram. Here is your bleed, and once this was embolized, this is the coil, the bleeding stopped. So whether the AVI is linear or round also determines what type of management you will end up doing most of the times. Imaging findings that are relative indicators for early catheter-directed intervention. So why would you think of sending a patient to interventional radiology or surgery? Obviously, contrast extravasation, as I showed, is pseudoaneurysm, an arteriovenous fistula, a high-grade injury, large volume hemoperitoneum, advanced patient age, and multi-organ trauma. Splenic injury. Let's talk about the organs one by one. This is the most common solid organ involved or injured in blunt abdominal trauma. Non-operative management, NOM, is now standard. It's considered standard treatment because it has many functions including a role in immune regulation. Non-operative management criteria, what are they? Hemodynamic stability, grade of injury, hemoperitoneum, age less than 55, number of transfusions required, and other injuries. Splenic injury diagnosis. How does it appear in CT? Hematoma would appear as a subcapsular, low attenuation lesion parallel to the margin of the screen. If it is intraparenchymal, it would have either round low attenuation, it could be poorly defined, it could have a jagged appearance. Lacerations, active hemorrhage or extravasation. Spleen can also have the propensity of forming pseudoaneurysms in case of trauma. Arteriovenous fistula, which would wash out on delayed imaging, and post-traumatic splenic infarcts or abscess are also other complications. American Association of Surgical trauma or organ injury staging for spleen grade 1 to grade 5. I will not go into the details, but the simplest fact is that the lower the grade, the more likely the management will be non-operative. And it saddens me that everywhere I go, I have to show American classification, Canadian classification, and European classification. I wish during my life I will see a day when I will display a slide that will show Pakistani classification of trauma, or Pakistani classification of research, or Pakistani classification, or I show pictures of Pakistanis who will sell all over the world and have brought that knowledge and have delivered it to the world and to us. Someday, inshallah, we'll do it. So here is a patient and two scans of two different patients. Here is a splenic laceration. You can see free fluid in the peritoneal cavity, and this was managed conservatively, did well. But this, as you can see, this is a shattered spleen. This will not do well. You can see active extravasation in multiple directions from multiple vessels. So this patient, you will not sit on this patient. This patient needs to go to surgery. Look at the size of this IDC and look at the size of this IDC. So this patient is hypovolemic. As I said, different things, hyper-enhancing bowel, if you see that, if you see the IDC collapse, if you see free fluid, a lot of free fluid, then you don't need to wait, you don't need to sit. This patient needs to either go to interventional radiology, just looking at the imaging, and understand your commands and stop breathing or cooperate with you during imaging. So that can be a problem too. Phase of imaging, obviously, it's a parenchymal, it has substance to it, so it can, enhancement pattern can be varying and can sometimes be problematic. All you have to do is do delayed imaging, do a different phase of imaging, repeat a scan of just the spleen. If you think that you're not sure it could be injured spleen versus artifact, just repeat the scan, and it'll solve the dilemma. So, non-traumatic lesions within the spleen which can mimic vascular injury in case the patient presents with trauma and you have no prior imaging to look at. Hemangiomas, islands of normal spleen surrounded by laceration or intact splenic vessels through the injured parenchyma can also sometimes be problematic. Liver injury, that's the second most common organ injured in blunt abdominal trauma. But if you combine the blunt as well as penetrating injuries, liver becomes the most common or injured organ just because of its size. It occupies such a large area that if you combine the blunt as well as the penetrating injury, it becomes the number one organ that is injured. Right lobe obviously is larger than the left, so it has more propensity or chance of getting injured. Right, obviously, another reason being that it is next to the ribs. So if there are rib fractures and there is a pneumothorax, you suspect a liver injury on the right. On the left side, less likely, but if it happens, if the left lobe of the liver gets injured, duodenum and pancreatic injuries are associated. 70 to 90% of liver injuries are minor. Non-operative management again is the norm, as in splenic injuries. As I said at the start of my lecture, that 85% of abdominal trauma is now managed conservatively, as long as it is imaged well and the study is diagnostic and the radiologist is competent. Ongoing hemorrhage in the liver setting is number one factor for failure of non-operative management. Again on CT, hematoma subcapsular or intraparenchymal. Subcapsular again would appear as low density surrounding the organ which is contained by the capsule, and laceration or contusion can appear like anything. It will be an abnormality, it will be visible. It can, depending on the type of injury and extent of injury, it can have variable appearance, but it will not give you if liver is injured, it will not have a homogeneous appearance to it. Lacerations could be linear, jagged, branching or low attenuation foci. Active hemorrhage and extravasation can appear as high attenuation foci which have similar enhancement to the aorta in or around the injured liver. Again, like spleen, we can get pseudoaneurysms which would wash out on delayed imaging. Intrahepatic IVC or hepatic vein injury would obviously make it higher grade injuries. Devascularization is rare.
because it has dual supply. Periportal low density can be a problem. As you can see here, the portal vein is enhancing. This is the portal vein. Portal vein is enhancing its branches, and there is periportal low density. See that? And this can sometimes mimic a laceration. What are the causes? Acute transplant rejection, liver cancer, liver transplant, heart failure, cardiac tamponade. Post-trauma, it can be seen in elevated central venous pressure from vigorous fluid resuscitation. But if you see this low density, all you have to do is give contrast, and that will differentiate it from this. Periportal low density would obviously follow the vessels, whereas the laceration will not follow the vessels. Again, staging, grade 1 to grade 6. I'll not go into the detail. The higher the grade, the more likely are the chances that your non-operative management will fail. So the higher the grade of injury, the more prepared you should be to refer the patient to our surgical colleagues, so that if something goes wrong, they are blamed. I'm only joking. Okay, so here are 4 different patients. Here is a liver laceration, was managed conservatively. Here is a liver laceration with fluid, managed conservatively. There is some fluid around the spleen as well. Now this region you can see, this is a laceration, goes through the portal vein, goes through the vessels. This patient, although did not have much free fluid, but this is a high grade injury. This is a grade 4 or 5 injury. So now to begin with, we know that this patient will, if this patient bleeds, this patient needs to go to OR. So this is a patient that we will not waste time re-imaging. If this patient becomes unstable, we already know this is high grade injury. So our threshold for referring it to the surgeon should be very low. We will not re-image this patient to see, oh, is there something going on? We know there is something going on already. We diagnosed it. Here is another patient with almost 60-70% laceration in the hepatic parenchyma. Again, not much free fluid. But if this patient becomes unstable, there is no need to re-image. This belly needs to be opened. Gallbladder injury, an uncommon injury. Only 2 to 8% reported in surgical literature. Concurrent abdominal injury with a gallbladder injury is 100%. So if you suspect a gallbladder injury, strongly you have to find another injury. It will not happen on its own. It will not happen in isolation. How can I say that? Because I have read the literature. You need to know the literature in order to understand your speciality. Just reading a book 10 years ago to do FCPS part 1 or part 2 is not enough. In order to keep yourself updated, you need to read the literature. Only then you will know what is going on in gynecology and what is going on in radiology and what is going on in pathology and what is going on in other specialities. It has to be done. It is difficult, I know. There are family commitments, there are many other things that we need to do, but keeping yourself updated is also extremely important. So CT findings of gallbladder injury are non-specific: abnormal wall, pericholecystic fluid, intraluminal blood, free intraperitoneal bile. But the most important thing to remember is, it cannot happen in isolation. So while the diagnosis of gallbladder injury on any imaging modality is difficult, at the same time it is easy because you will have something else. It will not be independent. If suspected, most specific exam is hepatobiliary scan, nuclear medicine scan, or now we do MRI with biliary agents, biospecific agents. Kidney injury is the third most common solid organ injured in blunt abdominal trauma. It's the most common in children. So if clinically a patient has hematuria and shock, it is equivalent to genitourinary trauma. If you have two things, hematuria and shock, renal trauma is there, period. Ultrasound, most renal injury, a study by McGann showed in 1999 that most renal injury patients did not have free intraperitoneal fluid. So ultrasound is out. Using ultrasound to look for free fluid is out because most injuries do not have free fluid. Only fraction of injuries are seen on ultrasound, which is 20%. CT is again the modality of choice. Kidneys at increased risk. Which kidneys are they? Horseshoe kidney. Anything but a normal kidney is at increased risk for injury. Renal ectopia, extrarenal pelvis, chronic reflux, hydronephrosis, cysts, for example, adult polycystic kidney disease, tumors. Now we again come to the stage. It's a recurring theme. The lower the grade, the more likely non-operative management. The higher the grade, the more likely you have to intervene, whether that is interventional radiology and embolization or whether that is clipping the kidney and taking it out. Few examples here. This is a paper by Kawashima. A gold standard, considered a gold standard when it comes to renal trauma. Here is a subcapsular hematoma. Stage 1, subcapsular hematoma, the kidney is still enhancing. This kidney could become problematic. This could become a beige kidney. As you can see, that there is contrast present within the collecting system here but not here. And the reason is that all this hematoma is impeding the blood flow to the kidney. This, you need to make sure you tell the surgeon that this kidney will be trouble down the road, but at this stage this kidney is not going to kill the patient. The blood supply is getting compromised, of course. If this hematoma, if this clot retracts, the kidney could do well. Does not, but at least you do not need to intervene. So this is a subcapsular hematoma stage 1. Let's look at stage 2. Stage 2 is lacerations that are confined to the perirenal hematoma, which is non-expanding, or a cortical laceration that does not go to the collecting system. Here is the left kidney. Right kidney. I need to get my right and left correct. So here is the right kidney, and here is a laceration that does not go into the medulla, just sticks into the cortex. A little bit of free fluid was present, but the patient did well. It was non-operatively managed. Grade 4, laceration that extends through the renal cortex, medulla and collecting system. Here you go. This is part of the kidney enhancing a large hematoma and multiple lacerations in the kidney that extended all the way. Avulsion of the uretropelvic junction. Here you got a kidney that has a hematoma around it. You cannot judge the collecting system or assess the collecting system unless it contains contrast. So you've got to do delayed imaging. In looking for renal trauma, you've done one set of imaging that shows you the kidney, enhancement of the parenchyma, but if you see a perirenal collection or blood, or you suspect there is renal trauma, you need to do another set of images. No additional contrast required, but you need to wait for the contrast to go into the collecting system. And here you go, look at this. This is the exact same patient. When we do delayed imaging, here is the collecting system and calyces, and the contrast is going down into the ureter. But look at this here. All the contrast has extravasated. And this is what tells you that there is a uretropelvic junction disruption, which obviously you cannot sit on. This has to be managed actively. Kidney injuries, several types of injuries are not accounted for in the grading scheme. Segmental renal artery injury, for example, main renal artery traumatic thrombosis. Grades 1 to 3, non-operative management is standard. Grade 4, observation or intervention depends on your surgeon or interventional radiologist and how the patient does clinically. Grade 5 injury nearly always requires intervention. Adrenal trauma occurs in 2% of patients, not in isolation. It does not happen in isolation. It is very rare to happen in isolation. Unilateral, right, or maybe bilateral. Ovoid elliptical shape with stranding. Mass lesion can be excluded only with follow-up imaging. Here is a patient that had that came in with trauma, a little bit of free fluid. Look at this adrenal gland. We were fortunate enough that we had a prior scan that showed that this adrenal was normal, and then we did follow-up imaging in 2 months, and this was cleared up and the adrenal was atrophic. This is the left adrenal. So this was traumatic hemorrhage of the adrenal gland. Pancreatic injury. Clinical exam is completely unreliable. Serum amylase. may remain normal in 1/3 of patients even with transaction of the pancreas. It should not, but it does. I don't know why. So you cannot rely on serum amylase if you suspect pancreatic injury, and you cannot rely on patient's symptoms. Diagnostic peritoneal lavage or fast retroperitoneum is a problem. Experienced sonographers, and these would be the sonographers that have been just doing ultrasound for years and years, 44% sensitivity. Even with CT, accuracy is only 68%. And this is the literature that supports what I'm saying. It is uncommon. Incidence due to blunt trauma is only in 0.2% of patients. Isolated injury is very rare, as I said. Mortality up to 20%. So mortality is significant. Acute is vascular injury. Delayed can cause problems like cyst, abscess, fistula, or even sepsis. Key is ductal integrity. In pancreatic injury, you need to look for the ductal integrity. If the duct is intact, you're safe. The patient is safe. There aren't major issues. If the duct is transected, the patient is in trouble. Inferred by severity of injury on CT, you can also do an ERCP or MRCP. Risk of abscess, fistula, substantially higher if the duct is injured. If the duct is intact, you can see it's only 10%. Pancreatitis can also occur. CT of blunt pancreatic trauma, the direct signs are contusion, pancreatic enlargement, and inhomogeneous enhancement. In all of these organs that I've talked about, if there is homogeneous enhancement, the chances of having an injury are minimal or dismal. So, enhancement of the parenchyma is of utmost importance for assessment. Laceration, transaction, and combination can happen. Linear hypoattenuated foci can be seen within the pancreas. Secondary signs are peripancreatic fat stranding, fluid collections, adjacent hemorrhage, thickened left anterior pararenal fascia can also be seen. Same as before, recurring theme. Higher the grade, more chances of intervention, more likely intervention will be required. CT grading of pancreatic injury, A, B, C, pancreatitis or superficial laceration would be A, B is pancreatic tail injury, deep laceration or transaction, and C is pancreatic head injury, again laceration or transaction. Tail you can deal with because the secretions come from the tail to the head and drain into the ampulla, so you can do a pancreatectomy in the tail or the body, but if it is in the head, it can be problematic. Two patients here. Here is the pancreatic head injury, but here is a pancreas that is transected, there is free fluid, and there was the integrity of the duct was not maintained. This patient had to go to surgery. This patient was managed conservatively. Oral contrast controversy. It was standard a few years ago to give oral contrast. We do not give it anymore. It was good for bowel evaluation or extravasation. The disadvantages obviously in an unstable patient are aspiration risk and transit time. You cannot wait for 1 hour for oral contrast to go all the way through the bowel and sit on the patient who might deteriorate in that 1 hour. And obviously if you have to operate, you do not want a stomach full of contrast. So there are too many problems with oral contrast in abdominal trauma imaging, and the consensus is not to give oral contrast, just to give IV contrast. Free fluid can be sometimes problematic. You do not see any injury to any organ, but you see free fluid on CT in the pelvis. Isolated free fluid without apparent solid organ injury. If the amount is moderate or above and location is upper abdomen, you suspect injury to the bowel. Physiologic can be seen in females who are menstruating in the pouch of Douglas. Small amounts can even be seen in males. A few ml can even be seen in males, and it's a normal variant. If truly isolated, 2/3 are negative for blunt abdominal trauma. Playing a poor hand well. Descriptors of injury with quantification when and if possible. When you're looking at CT, when you're talking to the surgeon or you're referring clinician, you need to make sure that they know what your gut feeling is. You need to communicate them. Just saying liver laceration is not sufficient. You need to tell them whether you think this patient will need intervention or not, what other injuries this patient have. Classification is equal to communication. Vascular injury, remember, increases the risk of failed non-operative management, so you need to mention that. Tailored protocols increases diagnostic accuracy. As well, I said, if you're not sure, do repeat imaging. If you're looking at kidney and you see collection around the kidney or fluid around the kidney, do delayed imaging to assess the ureter or the uretero-pelvic junction. Remember, 3Ds will get you anywhere in life. These 3Ds, anatomy, what are the 3Ds in anatomy? Does anybody remember? Come on, some of you, I'm sure, remember.
Dissect. Yeah, I think what is dissect?
Exactly.
Discuss.
Yes.
Very well. I will discuss it in a moment.
Okay, young fellas, do you remember 3Ds? No? Okay. 3Ds here are determination, dedication and devotion. Achieves the impossible. It will get you anywhere in life. If you have these three things, these three qualities, you will get anywhere in life. Nothing can stop you. And remember also, all things splendid have been achieved by those who dared to believe that something inside them was superior to the circumstance. Only then you will be able to do the impossible. You choose who you want to be. This slide is for your viewing pleasure. You choose who you want to be. And there are people in this room who belong to this category, and some belong to this category, and some belong to this category. And these are the three categories that are present in this room, and there isn't a fourth. Or that for that matter in the world, there are only three types of people. Objectives of the talk were summarize the abdominal visceral trauma classification, discuss the pros and cons of available diagnostic modalities in trauma setting, and signs and predictors in abdominal trauma. I'll take questions. Thank you so much. Yes, one doesn't have any biographical view to this. Unfortunately, yes. And the good thing is that it is a rare. The good thing is that unlike liver and spleen, pancreatic injury is rare. And it has high association with other injuries. So like gallbladder, pancreas, in isolation will be very infrequent. And, so that helps and facilitates the disadvantage that we have because of normal amylase or lipase. Pancreatitis, you virtually never have normal lipase and amylase, and the reason being that that's an inflammatory process, and there's a lot of inflammatory mediation in that, and lipase and amylase is a reaction to that. Here, there is no time for that reaction to happen. Injury happens suddenly, and 2 hours later the patient is in the ER.
Professor Khosa have given us such a wonderful information to us. I would like to give us some comments on the history that in the past when the CT was not available, then the primary aim for the treatment in blunt trauma abdomen was by the surgeons कि खोल कर देखते हैं क्या है. Clinically, if there is any suspicion of shoulder artery injury, then the only modality we do have is the ultrasound abdomen, which is a fast ultrasound abdomen. If there is any free fluid in the abdomen, so we suspect some sort of injury, most likely the liver or the spleen, because in renal injuries the hematoma is mostly retroperitoneal and there is no free fluid. But nowadays the minimum investigation required for blunt abdominal trauma is the CT scan. But this is happens in ideal situations. But in Pakistan, there are many centers, even like Faisal Hospital, we do not have a good CT scan which can do such kind of gradient in blunt abdominal trauma, liver injury, or splenic injuries, or renal injuries. If we do not have a good quality CT scan immediately and the patient is unstable, then what is your recommendation in that cases?
You need to open the patient. If the patient is unstable, the patient needs to go to the OR. don't waste time. Even if you have the best CT scanner in the world and the best radiologist in the world, you don't waste time. You take the patient. If the patient is unstable, the patient needs to be opened.
And the second problem here in Pakistan is that we do have a very few number of intervention radiologists, like who can do the embolization. And so in majority of the cases, whenever there is brain trauma, even after getting a CT, we have to go in and manage the case surgically, because intervention radiologists are very few available here who can be available around the clock, like in America or in Canada or in UK. So in Pakistan, the surgical intervention once again stands at the top for the management of surgical trauma.
Is good ultrasound machine and doctor and good serologist has edge over the CT scan in these cases?
Well, I showed you that the accuracy, let me show you the slide again, that with ultrasound, and there were multiple studies done with experienced sonographers and state-of-the-art equipment, and the accuracy rate was not commendable. Let me show you. See that? So, with experienced sonographers, with the best equipment, 31% matched the grading for liver injury, overgraded 6%, undergraded half of them, 53%, and missed 11% completely. Take the lead. Sometimes the pathologist will diagnose. It's not like, it doesn't work like that. It should not be like that. If it is like that, you're going in the wrong direction. You're going 180 degree opposite to the rest of the world. So, it has nothing to do with one person. It should never be. It always should be a teamwork. Yes, unfortunately, the principal or the medical superintendent gets suspended when this happens, the drug, whatever happened in Punjab Institute of Cardiology, for unfortunate incident. But was the MS responsible really? He was going to give the medicines that you give him. You know what I mean? So, why should the principal be suspended? Why should be an MS suspended? So unfortunately, these are great people because they take the main, they take the heat. Whereas whenever time comes for credit, all of you do. The entire institution does, It will be Fatma Memorial Hospital that saved the patient. It will not be the principal who saved the patient or vice principal who saved the patient. So these are great people who take the blame, But when it comes to credit, it is distributed equally, it should be distributed equally. Any more questions?
I think emergency rooms should have, for example, what I was recommending was that after listening to this talk, I think our emergency room should have like a protocol or an algorithm for the postgraduate trainees who are working in the emergency room, so that they know exactly that if the patient is unstable, we should not be sending and waiting, for a CT scan, a person to come and do the CT. They should immediately shift the patient. So, certain indications for taking the patient to the OR immediately and when to, start investigation, and I think it should be clear-cut, at least for the trainees.
Exactly, and that is where protocols come in.
Yes.
And that is, protocol, once it is agreed upon by everybody involved in the trauma setting, then no matter what happens, whether it is one patient or 50, nobody's ego will prevail then. If it is an agreed set of rules, it will save lives.
Yes.
And nobody will be able to take shortcuts.
Exactly. I think that was an excellent talk, and I don't know whether you're going to be here, but next time we should also do trauma to the spine and injuries to the spine.
Inshallah, I'll do that. I'll be more than happy to do it. Your principal has been very kind to me. He's invited me, and I'll inshallah keep coming.
That was an excellent talk. Thank you.
If there are no more questions, on your behalf and my own, I would like to thank Dr. Khosa for this excellent presentation which he has given. I think this is a sort of presentation which doesn't need to be just heard. I think it needs to be digested and then assimilated. And And I would request him that if he could allow us to put this presentation on our e-journal so that all of them can have a look at it whenever they like. And I entirely agree with Professor Nikhil that this was really an excellent presentation and very useful and appropriate one. So thank you very much again for that. Abdomen has always been thought of as a Pandora's box. And last time it was opened, most of the evils which we face these days in Pakistan, they came out and they are pestering us. There's only one thing left, and that's hope. So one hopes that one doesn't open the Pandora's box again. And I think after this lecture, one can see necessary equipment. You don't have to open the Pandora's box to see what is inside. You can plan what the problem is. So that's a good reminder. And as for the principals and the LSs or the hospital administrators being penalized, I think these scapegoats are not new. They have been there for ages. So whenever things go wrong, people do have a tendency to look for scapegoats. But you're absolutely right, that is not the individuals, it's the teamwork. And the responsibility also is a teamwork. And one should not penalize individual for things which they have not committed or which they are not entirely responsible. These are the faults of the system and they need to be corrected. Thank you for reminding that. And thank you again for the presentation.